Everyone. Welcome to today's webinar, Addressing Pain in All Stages of Life. Thank you for joining us. A few housekeeping things. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacist claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has been approved by NJOEMS for one EMT elective CEU. So welcome to our EMTs. The Partnership for Drug-Free New Jersey is approved by the Board of Certification Inc. to provide continuing education to athletic trainers, and this program is eligible for one Category A CEU hour. PA Planner Dean Barone discloses that he serves on the Speakers Bureaus of Ethicon and Johnson & Johnson, and all other planners, faculty, and reviewers have no relevant financial relationships to disclose. All relevant financial relationships have been mitigated. If you wish to claim CME or CE credit, you must do so within 30 days from today's date. After that day, unfortunately, we will no longer be able to issue you credit. And information will be available after the webinar on how to obtain that credit. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the Office of Alternative and Community Responses, the New Jersey Office of the Attorney General, and the Opioid Education Foundation of America. And I thank them all for their continued partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. And I'm so pleased to welcome today's expert faculty, Sarah Soretto. For those of you who have been with the learning series since its inception, you know that Sarah has joined us as a speaker on a few other occasions since 2020, but we're so glad to have her back today for a whole hour of discussion. She is a holistic board-certified registered nurse, and Sarah is passionate about providing well-rounded care to inform and empower individuals. She has been practicing nursing at Hackensack University Medical Center for 9 years. And so, Sarah, thank you for joining us. We're looking forward to your presentation, and I will turn it over to you now. I think, Sarah, you're still muted. We cannot hear you. No, there you go.
Thank you. Thank you, everyone. It's an honor to be here. Thank you for taking the time on this beautiful spring day to do some education and some learning with us. I'm going to be speaking about addressing pain across the lifespan. So, pain is a universal human experience. It is not something that really, as people, we ever get away from. From the very first cry as a baby to our last breath, the nature of being human tends to just go hand in hand with having some kind of pain, whether that comes from an event or it's just part of the grind of the human body. As providers, as family members, as community members, as friends, as coworkers, as family, it is important that we have pain in the forefront of our minds when we are interacting with humans across our life, because pain can be crippling. It can be motivating. It can do many different things for us as people. So it's important that we explore how to address pain effectively and safely through all different parts of the lifespan. So we're going to talk about, in the spectrum of life, what it looks like to really identify pain, to address pain, and to treat it. And in this current shadow of the opioid crisis, there's really no better time that we fully understand the spectrum of pain management. And as I said, it's important to be able to understand, what is pain? How is it experienced by each different individual person? And how is that affected by their age, by their lifestyle, by their history, by other factors in their life, by what they're currently going through, by what their future looks like? And how are we reacting to their pain as providers? How are they reacting to their pain as patients? How are we treating their pain? Are we creating care plans that are comprehensive? Are we co-creating a plan of care with them? And how are we managing their pain in order to have them be at the best version of themselves in their lives? Many types of pain affect people's activities of daily living, their ability to go up and down stairs, to get in and out of a car, their ability to speak. Are we managing that pain to give them the best version of life in their current situation as we possibly can? So, today, our learning objectives, we want to recognize and assess pain. We want to be able to compare how to properly recognize and assess pain across the lifespan in patients of all ages. And we need to identify appropriate and safe methods for treating pain in each of these age groups and differentiating them by age. The way that you treat pain in a neonate is going to be very different than you treat pain in a 6-year-old, which should be different the way you treat pain in a 25-year-old than a 40-year-old, 65, 85, 105. Every single patient is going to have a different need, and their need is going to be impacted by their age. We're also going to be discussing some alternatives to opioids, including some holistic methods. I am a board certified holistic nurse, so that is one of my biggest passions is practicing holistic care and bringing different elements of integrative medicine into my practice as much as possible. But most importantly, the meat and the potatoes, one of the biggest things that I want you to take away from this talk is practicing true individualized care. It is extremely important that we are not taking just standardized pathways, standardized order sets, smacking it as a band aid onto our patients and thinking that that's enough. Individualized care has to be at the root of all of the medicine that we provide. As practitioners, in the front of our heads every single day when we're assessing our patients should be looking at our patient as a person. It is extremely important when I provide care and when I precept new nurses, we're identifying their patients by their names, not by their room numbers, not by their diagnosis, but by who they are as a person. And that's critical to being able to treat pain. Adding personhood and humanity into medicine is part of what's going to make us be able to connect, develop rapport with our patients. And if we have that rapport, then we have trust. And once we have their trust, we get their full story. And a lot of pain, a lot of managing pain, understanding pain, truly seeing what's happening with their pain, we need to know their story. We need to know where they've been. We need to know what they've done. We need to know what they've taken in the past, their history. We need their full story and able to truly be able to best care for them. And in order to get their story, they want to give it to us. So, part of providing true individualized care is humanizing healthcare, is being able to connect with these individuals, not just a patient in the bed. Part of that is recognizing and assessing pain. So you'll see that I have nonverbal communication on almost every slide in this deck. And the reason why I'm going to keep repeating nonverbal communication is because it is critical. We're going to talk about scales. We'll talk about standardized scales. We'll talk about documentation. But one of the first things that you're doing when you're walking into, let's say, a patient room or outpatient in an office, you are assessing the entire environment. So that patient is already giving you data to work with before you have even introduced yourself, before they've introduced themselves, before any words have been exchanged, because you're getting nonverbal communication. And that nonverbal communication is going to be in their body language, in their eye contact, in their brows. Are they furrowing? You can see if somebody is in pain before they even say a word to you. Are you, as a practitioner, open to receiving that nonverbal communication the moment that you enter the room? That is part of recognizing and assessing pain. Looking at their nonverbal communication, absorbing everything that they're doing. So are they sitting uncomfortably? Are they wiggling around? Are they trying to tell you that they're not having pain and yet they can't stop moving because they're trying to get pressure off of one leg? So when you're walking into the room, part of it is doing a full visual up to down. And depending on where you are, so if you're in an outpatient setting, it's also checking who's with them. Are they driving here? Are they walking up and down the stairs? Have they taken the elevator? Are they arriving in a wheelchair when last week's appointment they arrived ambulatory? Keeping note of those things is also very important to understand pain, particularly when you're in an outpatient environment. If you don't see someone for, let's say, 2 to 3 weeks, when you're in an inpatient environment, are they sitting up in the chair? Have they been in the chair for multiple times? Or are you coming in, let's say you saw them yesterday and they were in the chair already by 9 a.m. and today it's 11 o'clock and they're in the bed. Does it have you thinking? Are you more uncomfortable today? Is there something preventing you from getting out of the chair? So all of that is nonverbal communication. Verbal communication is verbal. So that's communicating with your patient. Your patient's talking to you. Are they strained to talk? Are they in so much pain that they can't get a sentence out? Or are their words short? Sometimes you can assess if a patient is in pain not by just asking them, are they in pain, but how are they communicating with you? Are they frustrated? Are their words short? Are they a little bit curt? Are they so uncomfortable that maybe they can't say full sentences? And then communicating with the patient via words using standardized instruments. So you'll see there on the slide, there's a numeric pain rating scale. There are many, many different types of pain assessment tools. One of the core challenges in pain is that pain is very subjective. So, for effectively being able to treat somebody's pain, we need to be able to objectify a subjective situation in order to give it data. And all pain medications are managed by the DEA, and we have the Joint Commission. So as providers, we need to be able to have data to clinically, legally support our decisions. And that's why we're using standardized tools. So on top of using your nonverbal communication and your verbal communication, you're also using standardized instruments to be able to document and support clinical decision making. There are many, many different types of tools. Typically, the tools are used to give you some kind of idea of intensity, quality of pain, impact of pain, and you use them to be able to tailor your treatment. So, some of the tools that you will see in inpatient and outpatient settings are numeric rating scales, which you see on the slide there. So, that is utilizing a 0 to 10 scale, giving you a verbal answer of how much pain the patient is in, with 0 to 1 being none, 1 to 3 being mild, 4 to 5 being 6, and 7 to 10 being severe. And the idea here is then, as a practitioner, that you're adjusting your medications, severity of medication to severity of treatment to severity of pain. Those two things should align. There are also other scales, including the visual analog scale, which is a line. So it's like a 0 to 100 line. The Wong-Baker Faces scale, which is used often with children and cognitively impaired individuals. However, it's very popular. The Wong-Baker Faces scale is very often seen on communication whiteboards in inpatient and outpatient settings, as it gives the individual a visual representation of what that pain could look like if they have never thought about putting a number to pain before. So that is very common to see. And then there's the FLAC scale, which is like the facial expression, legs, activity, cries scale for infants and nonverbal patients. And in the pain assessment in advanced dementia scale, the pain AD scale is a behavioral observational tool for patients with cognitive impairment. So there are standardized instruments for many different demographics of patients, and there's also multidimensional tools. So pain is not linear. It is a very complex process. So although we have these standardized instruments, we cannot rely on them alone, which is why we are also doing our full assessment, including that verbal and nonverbal communication we talked about. Plus, if we have the time and capabilities, then we're also bringing in other multidimensional tools, such as the BPI, which is the Brief Pain Inventory tool. That is assessing pain intensity and how much pain interferes with your daily life. With when we're really looking at what are the goals of treating pain, you need to be able to treat pain so people can live. If pain is interfering into their activities of daily living where they're not able to function, that is not a successful goal for that patient. That patient's going to have individualized goals. And it's important to ask them that too. When you're doing a BPI, it gives you a bit more data than just the 0 to 10 scale, and you can communicate with the patient. What is your goal? You have some of these, let's say you have a chronic hip pain, a chronic knee pain. Tell me what your goal is. Let's say post surgical at the end of the year. What is your goal? And maybe their goal is, I want to get back to playing golf. That goal is part of what is going to drive their plan of care. And having that conversation with that patient is co creating the plan of care. You want to be able to give them autonomy and a voice in their care. So, using some of these multidimensional tools not only gives them more of a impact on their pain regimen because they're giving more data, they're giving more information, they're more involved, but it's also giving them the ability to co create the plan of care. The MPQ is the McGill Pain Questionnaire. That is a bit longer, and that one asks patients to select from 78 words that describe sensory and emotional quality of pain. Same thing as the BPI, that's giving you more complex information. And when we're dealing with complex issues, we need complex data to create complex solutions. There is no one size fits all for any patient. So, the more data, the more information, and the more information that we have about their pain gives us more flexibility to be able to co-create a individualized plan of care for them. The PEG-3 is a 3-item scale that measures pain intensity, enjoyment of life, and general activity. So similar concept. And then when we talked about ortho, there is a Swestry lower back pain disability questionnaire, and that is considered the gold standard for measuring functional disability in low back pain patients. So the idea here, and the reason why I wanted to put these different multidimensional tools on this slide, was to encourage patients and providers to patients advocate for yourself to be utilizing more tools that explain your pain if you have pain that is being either untreated or undertreated, and providers for expanding the box outside of the numerical scale. The numerical scale alone is not enough. It is not only giving you not enough data, but it is not involving the patient enough. It is not creating a co-creative plan of care where they are actively involved and autonomous in their care, and it's just doing your patients a disservice. So I wanted to add all of those multidimensional tools there to really enhance recognizing and assessing the pain, because the conversation with the patient needs to be more than where is your pain and how high of a number is it. So when we talk about pain, we talked about the age, the length across the age span. There are different ways that you can break down age. So the way that I broke this down is just your typical infant, children, adult, older adult. But what I will say is that I'm going to be talking about these age ranges more so. I broke them out more so just based on most of, like assessment and medication appropriability. However, there again, as we talked about before, there are no two patients that are the same. So just because you have a 3-year-old and a 3-year-old doesn't mean that they necessarily are going to have the exact same assessment. Doesn't mean that the same standardized tool is going to be appropriate for them. It doesn't mean that the same treatment plan is going to work. So although we're going to talk about generalities as addressing pain across the lifespan, there shouldn't be that much generability in your care. So a standardized pathway could be the root of care, but your goal is still providing that individualized care on top of any of your standardized pathways. So when we talk about infants and pre-verbal children, we're talking about roughly 0 to 3 years of age. However, neonates in the neonatal ICU typically have very different care than an infant not in the neonatal ICU. So depending on the environment where your infant or your pre-verbal children are, the care is going to look a little bit differently. When we talk about nonverbal communication in this patient population, we know the majority of the time, depending on how old the child is, if they are pre-verbal, you're not going to be getting an answer to what happened, what hurts, where's the pain. Asking those kind of questions is going to get you nowhere, right? So because we know that they can't say this hurts, this is what's happening, they can't give you details, we have to rely on observation. There's nonverbal key behavioral cues in this patient population. So in infants, you have on the screen there, I gave for you two different scales that are most commonly used in the inpatient environment. It's the FLAC scale and the CRY scale for postoperative pain. So the FLAC scale stands for face, legs, activity, cry, and consolability. So you scale the patient based on what you're seeing there, and then you calculate the points. The cry scale, same thing. It's crying, requiring oxygen, increased vital signs, expression, and sleeplessness. So those are standardized tools that you validate, that are validated tools that you essentially translate their behavior into a pain score. You take that pain score and you treat it appropriately based on what it is. So you're looking for, high-pitched crying, facial grimacing, changes in activity or feeding, whether they're difficult to console. And keep in mind, in this population, if you have a caregiver present, you want to lean on your caregiver to be able to identify what is not the norm for this patient. So you're looking to see, depending on who your caregiver is, let's say, dad and mom bring a 1-year old into the office and they're non-consolable. You need to know, what is it that's different? What is making them identify as non-consolable? Because your 1-year old is going to have a very different cry threshold than my 1-year old. And it's important that you identify that in the visit of, tell me the story, tell me what you're concerned about, tell me what you're seeing as caregiver, number 1 and 2, that's making the infant or child be non-consolable. Is it the crying, or is it the fact that they're wiggling around constantly? Is it that they're pulling at their arm? Are they splinting their body in? Are they guarding? What are the non-verbal cues that are giving caregivers the red flag to bring them in? It's also important to identify that newborn infants experience pain just as much as other individuals. The ability to assess, approach, and manage the newborn is the part that is challenging. So, in newborn infants, it's very common in the neonatal world. You will see them use like the comfort scale, the NPAS scale, there's a DAN scale, which are all premature infant pain profiles. So in the NICU and neonatal environment, it's a little bit different than in infants and, let's say, an outpatient environment. And that's just important to identify that it's depending on where you are, it's going to look a little bit differently. So the key is that you're tapping into your professionals within that world, tapping into your behavioral cues, to your caregivers, and really identifying what for this individualized patient looks different. Now, it's very challenging if there's no caregiver involved. So if there is no caregiver and you don't have a situation where you can kind of work off of someone to figure out what is different with this patient, then that's when you're relying on your standardized tools. And your standardized tools are there to be able to guide you. So you're looking at your scale, you're identifying the number, and then if you're a provider, you're identifying treatment appropriate to that number. If you're, let's say you're a nurse and you're an inpatient, then you're communicating with your provider. The FLAC scale is giving me a 4, I'm concerned, et cetera, et cetera. So in infants and preverbal children, a huge piece of this is nonverbal communication. That continues despite even being verbal. As we talked about before, nonverbal communication is going to be your number 1 point of assessment when you initially meet any patient. So in younger children and even adolescents, the nonverbal communication might start to look a little bit different. There should still be that emphasis on you looking at their face, their body language, their physical communication. Are they moving? Are they not moving? Are they not ambulatory due to pain? Are they curled up in a ball? This little girl in this picture is guarding. Is she guarding her stomach? Because that's where her pain is. So you're doing your nonverbal assessment first. And then this is the age where they can begin to self-report. So it's very important to establish rapport and trust in this patient population. It's important to be able to connect with them in order for them to feel comfortable communicating with you. But also keep in mind, it's very common in this patient population, particularly on the younger end, to not want to communicate with you regardless, despite your deepest, best efforts, if you try your hardest to connect, because that's just appropriate for their age group. If they are, uncomfortable and hiding behind mommy, that is not your fault. It's 100% expected in this age group. But with more time and consistency in caregiver, you typically will see that the children will start to open up a little bit and talk to you a bit more. So, a tip in this patient population, really in all patient populations, consistency is always helpful. If you can have consistency in provider, it does give you a little bit of an edge as they feel a bit more comfortable. And as we talked about before, they might give you their story. And their story is really what is going to help you as the detective, because you really are a detective in medicine. It's going to help you get to the bottom of what's going on and help you be able to appropriately treat it. So, this is a very wide age range. 3 to 18 is kind of your young children, adolescents. However, you're treating, you're assessing, and your co creating plan of care with a 3-year-old is wildly different than with a 17-year-old. The moral here is that they're going to self report differently depending on each individual. So, part of that is also getting to know them as a person if possible. Depending on the setting that you're in, if you're inpatient and you're rounding on your patients and you see them every day, that will give you a little bit of a leg up. If you're outpatient and you have some consistency and you're seeing them once a week, then that will give you the ability to understand their personality a bit more, see, who they are, what they're like, what their lifestyle is. In this age range, it's still very often that you will see the faces, the Wong-Baker faces scale. That is particularly helpful in younger children that are not pre-verbal. They are communicating, but not expressing a wide range of emotions yet. So this series of faces starts off as smiling when you're in no pain and then gets a bit more uncomfortable and then ranges into a full cry. So that helps represent their pain because they can see and they can visualize with that face of what the different kind of appropriate face would be for how they feel. And then they can pick a face that best identifies how they feel at that moment, which is helpful also using that visualization skill. So you have some people who are better able to connect with the idea of pain when they're looking at the face. A key consideration in this group to really be aware of underreporting related to a fear of a procedure. So many children might underreport pain because they are afraid of either getting a needle, an injection, a medication, or they're just fearful of the environment. And something to use in this patient population is play for education, play for giving them the comfortability of what's going to happen. So, for example, if you have, let's say you have a pediatric oncology patient who gets a port draw that is a needle into their port to draw labs, and let's say they have to get that done once a week. It is pivotal to be able to give that patient the autonomy to play with a doll and show them what is going to happen. So, what you want to do is you want to explain the entire procedure to them and utilize something that they can get their hands on. So, in some of our facilities, what we have is a doll that has a port and a fake needle, and we show them and we have them play nurse and they clean the port and they access the port and you can see the patients sometimes they love it and they'll play nurse and they'll say it's going to be a quick pinch, here we go, and they literally mimic everything that you say as a nurse, and it is the sweetest most wholesome thing in the world. But what you're doing there is you're using play to take away the mystery of the procedure. And in this patient population, really in all of them, but in this one particularly, they can't visualize what something's going to look like until they see it. And in order to walk them through it, sometimes they need a hands on. If you don't have that ability, then at minimum, you want to talk them through as much as possible, appropriate to their age where they can understand. So you can say, we're going to wheel into another room. Your parent is going to sit right by you. I'm going to be right with you. We're going to apply a little bit of cream. It's going to make the needle not hurt too much. There's going to be a small pinch, walking them through the situation and giving them the ability to hands-on play decreases some of that fear of just the unknown. And in this patient population, you have to be mindful that they can truly underreport pain because of the fear of unknown, because of the fear of procedure, or because they've had procedures before and they don't want another one. So they're not going to tell you that they have pain because they don't want the procedure. So then you really are relying on the nonverbal communication, the connection to the caregiver to understand what the pain is past that verbal, let's say, answer that they give you. And you want to look at their impact on their function. So if they are saying that they're okay, but they're curled, they're huddled up into a ball, and they're extremely uncomfortable looking, and they have grimacing, and their eyebrows are furrowed, and they haven't eaten, they haven't drinking, they haven't ambulated, that is all telling you that this could be an underreporting situation because of fear. And the impact on function is critical because, again, the goal is to get people back to their baseline. In the adult population, many of these things are still the same. Nonverbal communication is equally as important in the adult population, particularly when you are dealing with cultural considerations. So it is very common to assess a patient, ask them if they have pain, and them say no, because there is a cultural faux pas. I have experienced it many times in my own individual practice where patients will feel in a different array of emotions where they either feel that they're not allowed to have pain, they feel proudful where they don't want to have pain in a situation that they maybe didn't think they were going to have pain in, or they are maybe undereducated about the importance of treating acute pain. So, therefore, they don't want to take a necessary medication to get through pain. And so, therefore, they just don't report the pain and they try to hide it. So, the cultural considerations are critical in adults, also important in all other age populations, but in adults, in my personal practice, I've seen it be a little bit more heightened. So, same thing, nonverbal communication, depending on the setting that you're in, you are assessing the moment that you open the door, you're assessing the moment you pull back the curtain. You should be getting a full visual of what is going on, taking a look at their face, their body language, and then lifestyle considerations. So, when we're talking about pain in adults, what are they doing? Are they in a painful job? Are they in a job where it's very physically demanding and now they're coming in with multiple different types of painful issues related to the workforce? Are they having, let's say, similar pain issues in one limb because they aren't able to take off work because they can't miss a paycheck, but they keep coming back in with the same type of pain in their same ankle because they haven't actually been able to treat the injury because of inability to take off? All of the lifestyle considerations have to be into play when you are treating these patients. Their pain tolerance is also going to be directly related to their surgical history, to their lifestyle history, to their medication history. When you are seeing these patients, you have to have a full story. So, has this patient been on any pain medications in the past? What do they take on a daily basis? What is their pain threshold? So, if you have an individual that takes 1,000 milligrams of acetaminophen for a headache 3 times a week, that patient's going to have a different pain threshold than an individual who hasn't taken acetaminophen since 1985. And these are things that you need to know. And when you're getting their history, the conversation doesn't have to be, tell me everything that you've done since you were born. It's fluid. It's okay. So when you get headaches, what do you typically do? They'll say, I don't get headaches. I don't take anything. Or they say, I take 2 extra strength Tylenol 3 times a week. These are part of the things that you need to consider as a practitioner of what is their pain tolerance. Or are we treating individuals that have chronic pain? And now they're coming in for an acute procedure. Their doses have to be adjusted when they have an increased pain tolerance. And if we don't acutely manage their pain, that is only increasing the risk of misuse, of mismanagement, and of worsening chronic pain. It is critical that we are treating the acute pain to prevent chronic pain or to prevent worsening chronic pain. So, having a full conversation with these adult patients, including the complex questions of what is your medical and surgical history and how did your pain get better after some of those things that you had. So I want to ask them and I want to know, when you had your appendectomy, you had your appendix taken out 5 years ago, were you home that night? And if you were home that night, were you taking any pain prescriptions, or were you just taking Tylenol, or were you taking nothing? And if they say I was admitted for 6 days and I had a drip and I was pushing a button, that's going to change how I'm treating them now because I know how they had gotten treated before. So, in this patient population, as you're doing your assessments, you can do your numeric scale, you're going to do your standardized tool, but that's only a starting point. A full comprehensive assessment is vital, exploring all of the pain quality, all of the details of the pain. You want all of the adjectives. Is it burning? Is it throbbing? What are we feeling? And the impact on their daily mood, their function, their sleep. What's making it better? What is making it worse? You need to know all of these details in this patient population. You need to know all the details in all of the patient populations, but this patient population should theoretically be able to give you the answer a little bit more clearly than the other patient populations. So now when we talk about older adults, we're talking about 65 and older technically, when we look at generalized age brackets, but in older adults, that there, we can go all the way up to 105 depending on what part of the world you live in. So nonverbal communication in these patients might be a little bit different. Older adults often can be underreporters, and there can be some cultural considerations in there too. Sometimes, depending on the individual, some older adults can feel that they are a burden. They don't want to complain. Some of them can feel that they've put their children and their families into situations where they are essentially back in the cycle of life and they feel like they are wreaking havoc on their family. And that can be challenging because that can prevent them from telling you as a provider what is going on. Because, again, similar to children, underreporting to prevent procedures. I have had patients that after weeks of care and really developing rapport have been able to say, I know you're going to send me for another x-ray, and I know then they're going to do an MRI, and I know they're going to say they want to do a surgery, and my daughter can't take off more work. We can't do a surgery. We don't have the time and the money for it. There's going to be so many different complex elements of personhood that can impact reporting in this patient population. So pain in this group is very frequently under-recognized and undertreated. There are unique challenges in this group. Older adults may also not use the word pain. They may use more descriptive words. They might say soreness or aching or discomfort. So it's important to be able to identify in this group that they might not always report pain as clearly or as directly. As we talked about, under treating acute pain is a direct line to chronic pain. So we have to be sure that we're doing a thorough assessment and treating their acute pain appropriately. Cognitive conditions like dementia can make self-reporting impossible in this patient population. So you're going to use your standardized observational tools similar to those used for infants. However, there is one that we use in my facility that is specific to dementia. That is the Pain Assessment in Advanced Dementia Scale. So you'll use that to ensure that you're appropriately assessing these patients that are unable to give you a full detailed description of what's going on related to their cognitive dysfunction. And their self-reporting barriers, as we talked about before, might be cognitive or they might be from personhood. So look for those descriptive words, look for misconceptions. And when we talk about misconceptions, we're also talking about their misconception of opioids. So something that can happen in younger populations as well, but I've personally seen more commonly in the older adults, is a misconception of how opioids are used and how opioids are going to impact their life. So I have seen individuals that have fear a fear and a lack of education or a lack of understanding, or nobody's ever explained to them the importance of treating acute pain. And they will have a misconception that treating acute pain, let's say post surgical, with Percocet to increase their ability to ambulate, which is crucial for preventing pneumonia, DVTs, etc. They will be fearful that that's going to make them an addict. You have to really look out for those misconceptions in this patient population and treat them appropriately to ensure that they are getting back to their activities of daily living, and be sure that they're not avoiding pain interventions and not avoiding treating pain because of their misconceptions of the use of acute medications. So when we talk about tailoring pain to different age groups, we talked about personality, experience, lifestyle, we talked about caregivers. It's really the goal here is that we're co-creating the plan of care as holistically as possible. So we're looking at the entire individual, not just the one problem that they have. Non-pharmacologically, there are going to be different things that you can do by offering different comfort measures for infants and children that can work throughout the entire lifespan. But in the infant and children population, non-pharmacological comfort measures very often help get them over the hump of just being in the actual healthcare environment, where you can even calm them down so that you can do a full assessment. So part of that is in the neonatal population is swaddling, offering a pacifier, skin to skin contact. As they get a little bit older, it's distraction, it's play, it's connection, having like friendly conversation, bringing humanity and personhood back into their care. All of that, the goal is just creating a healing environment so that way you can fully do an assessment, manage the appropriate medications, and treat the patients. Tap into your child life specialist if you have them in your facility. If you don't, I highly recommend trying to advocate for getting them into your facility. And with pharmacological treatment in this population, be sure to do weight-based dosing and alternating a schedule. So if you have the need for opioid medications, you still want standing non-opioids on board, and you want to be alternating those where you have, let's say, your non-opioid medication standing every 6 hours, and then your opioid is used for breakthrough pain. In the adult population, your non-pharmacological interventions are going to be very similar. You need to be offering physical therapy, movement, splinting, and we talk about these on another slide. But non-pharmacological should always be at the height of your head. So when you are treating a patient for pain, you want to be thinking, how am I treating them pharmacologically and non-pharmacologically? And they can be at the same time, or they can be together, and you're using them as like a bridge to each other. Individualized comfort measures are important. Sometimes we think of it as adults that like having your favorite stuffy doesn't matter, but that's not true. As an individual, when you're an adult and you're going through an acute crisis, having things that are from home, having things that bring you comfort significantly increase your ease in an uncomfortable environment. So creating that healing environment is critical for all of these patients. And across the lifespan in adults, part of creating the healing environment is giving them autonomy to bring in what they need. So in inpatient, that's saying to them, bring in the things that help you get through these challenging times. Active listening to these patients, ensuring that you're fully getting their story, consulting specialists, including your pharmacists and your pain palliative team, also using the alternating schedule and using the analgesic ladder. So that's like the general approach is you're starting with the non-opioid analgesics, you're using them on a schedule if appropriate, and then you're adding the stronger medications when they're necessary. So that way you're bridging up the ladder. Now, in the older adults, you do need to be mindful of polypharmacy. So, in these patients, your pharmacist is going to be your best friend because their metabolism is different. Their interactions with all of their medications are going to get a bit more complicated. So, pharmacologically, in the older adult, you also are alternating their schedule. You're also using non opioid pain medications, but you're really heavily leaning on your pharmacist. Non-pharmacological interventions for these older adults are going to need to be kind of consistent because you're going to have individuals that are more uncomfortable, let's say more percentage of the time with more chronic pain. So you're going to want to have all of those same comfort measures, all the same healing environment, utilizing your family, utilizing your resources, but having a little bit more consistency in treating that standing pain. So when we talk about alternatives to opioids, non-pharmacologically, there is physical therapy and occupational therapy because movement is medicine. You need to be moving your body around. And even if you have issues that are preventing mobility, the max mobility that you can do as an individual is still what you should be doing. So even if that is just your wrist movements and your finger movements and your neck, that should still be happening on a daily basis. The mind body spirit connection is critical. You need to be making sure that these patients are practicing on a daily basis. What are their goals? Are they decreasing anxiety and stress in their life if they can? Are they managing it appropriately? Are they developing healthy coping mechanisms? Are they resilient to stressors? Things like guided meditation, stretching, Tai Chi, Qigong, those are all really great alternative therapies that can be added into their medicine plan of care. And that's always my goal as a holistic nurse. My goal is always to have a holistic environment where we're integrating medicine and holistic medicine together to make the best options for the patient. So you'll see chiropractic medicine, acupuncture, TENS therapy, heat and cold therapy, CBT therapy, which is cognitive behavioral therapy. That helps patients reframe their relationship with pain and really develop their coping skills. Radio frequency ablation, I have never personally used, but it's using heat to quiet a nerve. And I have had patients that have had it and have had great results. Aromatherapy as distraction, as connecting them while they're doing guided meditation. Bring in a holistic nurse if you can to do a holistic eval. Surgery, manual therapy, there's a lot of options. From a pharmacological standpoint, there are NSAIDs, acetaminophen, gabapentin, Flexeril, antidepressants, anticonvulsants, and topical agents such as like lidocaine. These pharmacological alternatives can all be used in conjunction with opioid pain medications to acutely treat them. Keep in mind, this has to be tailored to the lifespan, right? So NSAIDs are not safe and not used almost ever in neonates, except in particular situations. They're not that recommended in children. Acetaminophen is more widely used because of its safety profiles. And in the older adults, you need to be very mindful of polypharmacy with things like your gabapentins, your anticonvulsants, and your Flexerils. So you have to really tap into your pharmacist when you're treating patients with these kind of alternatives. I'm sorry I went kind of quickly towards the end, but I wanted to make sure we didn't have no time for Q&A. So the moral of the story is that there's no one size fits all. Everything has to be individualized. The goal is co-create the plan of care with the patient and tap into your specialist to really find the best solution for that patient. I'm ready for questions.
Thanks so much, Sarah. That was a great presentation and so much information. And I know that we had some questions about um, in the chat, and we'll get to this in a second, but I do know that people are looking for some additional resources and information. And again, I just want to share that we will be sharing a copy of this presentation and the slides with all of those in attendance. So I just wanted to mention that. But we have a lot of different people on with us. But one question that seems to come up, you talked about looking at what people did in the past and kind of making their plan moving forward. So how do you recommend talking to someone or convincing someone to look and explore some of the alternatives? I know you and I have had this conversation before, and then when you talk about things like, like aromatherapy and things like that, and we get that feedback of saying like, no, I need a prescription. But so can you talk about that? Like how can
Sure.
we have these conversations?
So I always offer holistic therapies as adjunct therapy, and the way that I describe it to my patients is, depending on the patient in front of me, sometimes I say, "I'm going to talk about something that might sound a little bit like juju medicine to you," and I understand that. I understand that it's maybe something you're never comfortable with, but it's not going to harm you. And what I want to say is let's try it. Let's try it as an additive and let's use it as a bridge. So, specifically in my practice, I have a lot of complex pains in joint pain from metastatic cancer. And so, what I'll say to my patients is, I can't change the fact that there's cancer in your bone right now. We're waiting for radiation to do its job. We're using our, dilaudid on a schedule so that we can ambulate you and get you moving and prevent all the complications of not moving. But I want to try using some black pepper oil on that spot, and it's not going to cause you any harm, but maybe what it can do is give a little bit of time when we're trying to bridge to our next dilaudid. I'm trying to extend the time just a smidge so that way there's something that we can institute something while we're waiting for our next opioid. And if it's somebody who thinks that I'm crazy, I say the worst thing that's going to happen is you're going to smell a little bit like cacio de pep, and that's okay. Nothing bad's going to come of it, so let's just try. And many times it gives them the autonomy that they say to themselves, oh, I can put my black pepper oil cream on while my dilaudid is due in an hour. I'm going to do that now because I know that I can't have it yet. And you're giving them back power. You're giving them a toolkit, a device that they can do. So that's part of how I frame it to them is like, let's try it. Nothing's going to happen. Nothing bad's going to happen. So let's try it. And I'm going to put you in the safest place I possibly can. So if you trust me, I trust you. Let's give it a shot.
No, I think that trust is so important, and I know you touched on that um, throughout. One other thing that I know you mentioned is the importance of patient education, right? And so, as you know, that's something that we talk about a lot, about the idea that notifying and making patients aware of potential for dependency and addiction of opioids and other alternatives that exist. But can you give some thoughts on that, some tips and thoughts?
I think one of the biggest things is if you have somebody who has never taken a prescription drug before, one of the most important things you have to teach them is looking out for side effects and being aware of their own, like they have to be self aware of their own pain management. So, what I explain to them is, I need you to really be tapped into like what that pain feels like for you and not taking pain medicine on a schedule. And if you start to feel like you just want to take it because it's the time on the clock, that's when you need to sound the alarm to one of your other, your family members and to me as your caregiver. And I think the education starts by a true sit down, honest conversation, block out enough time in the schedule where you're eye to eye, you're having a true open heart conversation so that they understand what's going on and really doing an assessment of their level of acceptance and like of their learning. Do they need a paper? Do they need a printout? Do they want to watch a video? Figuring out how they learn best is like step number one. And then once you figure that out, getting on their level and giving them the time to explain through everything that they're doing and really empowering them to ask as many questions as possible.
I know we're coming to the end of our time, but before I go to your final thought, I did want to ask you, how can we support and, advocate or empower hospital systems or, to allow this kind of conversation about these multimodal strategies?
You need data. You need to be able to put the work in. It's all about the Benjamins, right? It's how life works. So you need to come in with a study and show, you need to be coming in with institutions with studies that show data that have had improved patient outcomes. And then I recommend a facility that does not have any kind of integrative medicine bring it as a quality improvement project. So find a patient population that has, let's say, I could use my department for an example. We do a lot of bone marrow biopsies. So find a department that does a lot of bone marrow biopsies, somewhere that that is a painful procedure that is happening, and do a study on those patients with and without some kind of holistic medicine. Do a scale, do a patient experience scale, have them fill out a survey, and bring that data to your board. So you need to be able to show them the intervention has value. And in order to get them to give you money to create programs that offer more holistic medicine or integrative medicine, you need data. So it takes work. You have to start projects. You have to show the time and the value. And I would connect it to patients, like having patients have experience surveys is very helpful. And you can connect it to quality measures like their pain management. And you can do chart audits, show the actual numbers, but you need the data in order to get their buy-in.
All right, great. Well, I know we're at the end of our time. I just wanted to leave you with the opportunity, if there's one final thought you'd like our attendees to take with them today, what that would be.
Um, I think I said it like 1,000 times. I feel like my final thought would just be to really make sure that you're connecting with your patients as people, to really see them as not just a number, not just a diagnosis, to connect to them as individuals and think of where they are at in their lifespan when you are doing your assessments. So that way you can provide the most, holistic possible plan of care and address their pain from all measures.
All right, great. Well, thank you again for your time today and your presentation. Thank you to all of our attendees who joined us today and who took the time to learn about this very important issue. So I want to thank you again all, and I hope that you will join us on April 23rd as we talk about the public health risks of counterfeit pills. Now, we addressed that back in January a bit about some of the other drugs on the market and opioids that like the gas station heroin and such. So I hope that you'll join us to continue that conversation. Thank you again, everyone. Enjoy the sunshine today. Hopefully you have it in your area that you're joining us from. But thanks again and have a good day, everyone.
Thank you, everyone. Have a good day.